management of rheumatoid arthritis, as you will discuss today in your PBL session, the case related with rheumatoid arthritis and osteoarthritis. Our main focus will be on the rheumatoid arthritis because there are many options now that we use to treat rheumatoid arthritis. Second important thing that rheumatoid arthritis is unfortunately a lifetime problem. It is irreversible, although we know that it is autoimmune disorder. We don't know exactly, but our own antibodies become our enemies and they damage the joints of the different joints and they affect the joints of the body symmetrically, both sides. If the right side joints are affected, for example, of the knee or the wrist or the hand or anywhere in the body, so the left side will also be affected. That is called symmetrical. The big picture for the treatment of rheumatoid arthritis, because I think you also discussed with Dr. Abdurrahman the autoimmune disorder. It has its own different type of antibodies. Here, the problem that we face, that is the inflammation because of TNF and rheumatoid factor made by the B cells. TNF stands for tumor necrosis factor. Tumor necrosis factor. Tumor necrosis factor, these are the inflammatory cytokines. They cause inflammation in the body. Similarly, the factor, rheumatoid factor, which are made by B cells, and you know B cells are part of the white blood cells. In white blood cells, we have T lymphocytes and B lymphocytes. So these are the B cells. Hope you also discussed it in histology. Our focus will be to decrease the inflammation, because this inflammation results in severe pain, as well as because of these inflammatory mediators, the cartilages, the collagen, the joints, they are affected severely. So it is a kind of degenerative disorder. That means that it will continuously damage the joints due to this inflammation. So what we will do, that we will try to minimize or reduce this damage. Okay. How to fix it? So first one, as I told, that there is severe pain. So to manage the severe pain, we do the symptomatic management to decrease the non-specific inflammation acutely. We give NSAIDs and glucocorticoids, non-steroidal anti-inflammatory drugs and glucocorticoids. Both of them, they reduce the inflammation acutely. Acutely means very quickly. It is a matter of, you can say, hours or days. When we start, the patient start relief within a 1 or 2 days. Modify the disease progression. What I told, that because it is autoimmune and the antibodies, they continuously damage our body joints. So to control this, what we do, we have different options. The first one, and that is the most common and you will find everywhere, that is prevent the synthesis of DNA that is required for the leukocytes. You know leukocytes, they are the white blood cells. And as we discussed, that white blood cells, there are T lymphocytes and B lymphocytes, and they are one of the reasons for this inflammation. So we have MTX or methotrexate, as we will discuss in detail. Then we have leflunomide, it is also same, and the third one is azathioprine. These three, they prevent the synthesis of the DNA that is required in the leukocytes. The second group decrease or modulate lymphocyte action. Lymphocyte is again white blood cell. If you remember, I told you in the beginning that never let monkeys eat bananas because monkeys like bananas, or no? Yes. My computer please. Okay, so lymphocytes are the second largest number of the white blood cells. First one are the neutrophils, second one are the lymphocytes, and because they play important role in the inflammation in the rheumatoid arthritis, so we decrease or modulate the action of the lymphocytes. And again here we have two drugs, one is hydroxychloroquine and the other one is sulfasalazine. Then we go to next, that is more specific, as we discussed in the beginning, that the reason for the inflammation is tumor necrosis factor. So tumor necrosis factor blockade, we can do it by etanercept, we can do it by infliximab or infliximab, whatever you like, and the third one is adalimumab. I know these names are new, difficult, but you don't need to recall all the names. Then we go again more specific, B cells, as we discussed in the beginning. B cells are important in the inflammation that is related to rheumatoid arthritis, and that is rituximab or rituximab, whatever you like to pronounce. Then we go again more specific, T cell stimulation, because T cells, they are important in the T lymphocytes. So that is abatacept. Abatacept, they specifically act on the T lymphocytes. Then we go to block the interleukins. I think you might have discussed with Dr. Abdurrahman in the immunity. There are different types of interleukins, and these interleukins, they also cause inflammation. Two of them, we will take them, IL-1 and IL-6. IL-1, the drugs that will block the interleukins which are related with IL-1, that is called anakinra and canakinumab. Anakinra and canakinumab. And the last one, but not the least, because you will find patients in your clinic nowadays, they are using this, that is interleukin 6 inhibitor. Interleukin 6 inhibitor, and that is tocilizumab. Tocilizumab. Okay, so that is the big picture of the rheumatoid arthritis. Not going. Okay. Next, as we discussed that the management of the rheumatoid arthritis is symptomatic, and second one, to decrease the progression of the disease. So first what we will do, that we will do the symptomatic management. We will give the drugs that should reduce the pain of the patient. Okay, so in this case, the first one that are the NSAIDs, are non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs. In non-steroidal anti-inflammatory drugs, the first one that is called the prototype, that represents the group, that is aspirin. But aspirin, interestingly, it has many roles, and that roles that depend on the dosage. Low dose, it is what we say antiplatelet drug that is used in the treatment of cardiovascular problems. In high doses, it is an NSAID, non-steroidal anti-inflammatory drug, or anti-inflammatory, analgesic, and antipyretic. So low dose, primary and secondary prevention, MI. MI stands for military intelligence. Askari. What is the role of Askari in medicine? Mafi, yeah? MI stands for myocardial infarction. I just told you that it has role in cardiovascular diseases. So myocardial infarction, there is thrombosis, and it can reduce the platelet aggregation. But here the dose is low. Small dose or low dose, maybe 40 milligram. We discussed also in cardiovascular, 81 milligram, 100 milligram. That is for the primary and secondary prevention. It is not the treatment. It is not the treatment. Now we come to the high dose, rheumatoid arthritis historically, previously we used very commonly. And we can also use NSAIDs, aspirin, for acute MI. To treat acute MI, again, myocardial infarction, we use larger dose, maybe 325 milligram to 500 milligram. The dose that is used to treat pains, the dose that is used to reduce temperature, the dose that is used to treat MI, that is 325 to 500 milligram. Okay, so what are the side effects? Aspirin is very effective in the management of pain, but unfortunately it has problems. And what are those problems? That it causes gastritis. It damages the GI mucosa, so that leads to GI ulcer, what we say gastric ulcer, as well as gastric bleeding. Second important problem that we face with aspirin when we use it in larger doses for quite longer duration, that it can cause tinnitus or tinnitus, ringing in the ears. The patient thinks that there are some ringing in the ears. So that is second problem that we face with aspirin. Third one is renal failure. Renal failure is also sometimes happens because it acts on COX enzymes, cyclooxygenase 1 and cyclooxygenase 2. These are the enzymes which are required in the synthesis of prostaglandins. COX-1 and COX-2 are cyclooxygenase 1 and cyclooxygenase 2. These are the enzymes which are required in the synthesis of prostaglandins. And prostaglandins, some of them are good for us, like prostaglandins which are in the GI, it gives protective layer. The prostaglandins which are in the kidneys or renal tubules, it increases the blood supply or the blood flow. There are prostaglandins that can cause inflammation. So aspirin blocks both, whether they are good prostaglandins or whether they are bad prostaglandins. So that lead to renal failure. When we block COX-1 or cyclooxygenase 1, that leads to renal failure. And the last one, that is Rye syndrome. Rye syndrome is the problem that is in children, atfal, below 12 years of age. If it is used as an antipyretic, the drugs that reduce the temperature or brings down it to the normal, and the patient is child and the patient is suffering from viral infection, it can lead to Rye syndrome. Rye syndrome, it can damage the liver, it can damage the brain, that is encephalopathy. So, and it could be fatal. So the take-home message that aspirin should never be used below 12 years of age. Itnash. Below 12 years of age, we should not use aspirin. Okay, go to next. Because of these many problems with aspirin, we have some more NSAIDs. In these some more NSAIDs, if we speak clinically, they may be good as aspirin, but the side effects are slightly less. Okay, ibuprofen, indomethacin, and naproxen. Mechanism of action is same, that they will block the COX-1 and COX-2, but with one difference, that aspirin blocks COX-1 and COX-2, again I am repeating, cyclooxygenase 1 and cyclooxygenase 2 irreversibly. But ibuprofen, indomethacin, and naproxen, they will block the cyclooxygenase 1 and cyclooxygenase 2 reversibly. Once the effect of the drug is gone, maybe after 6 hours, maybe after 8 hours, maybe after 24 hours, then what will happen, that the COX-1 and COX-2 will be there. But in case of aspirin absolutely blocked, the body needs to synthesize new cyclooxygenase, either 1 or 2. Cyclooxygenase 2, the body produces when there is inflammation. So we say they are found in the inflammatory cells. Okay, so amount of COX-1 and COX-2 blockade changes depending on the agent. Some of them, they will block equally, like ibuprofen blocks COX-1 and COX-2 50-50. 50% COX-1 and 50% COX-2. Indomethacin may be slightly better than ibuprofen, and then naproxen slightly more. For example, you can say naproxen 65 to 70% COX-2 and 30% COX-1. So that is what we say, the amount of COX-1 and COX-2 that is blocked. Then we come to the uses. We use it to treat fever, to reduce the body temperature, to treat the pain, analgesia, and we also use it as anti-inflammatory drug. Again, because even the percentage or the amount of COX-1 may be less as compared to aspirin, and secondly, it is reversible, but still it blocks COX-1, so they will also cause gastritis or gastropathy. It will damage the GI mucosa. So there will be ulcer as well as bleeding. To overcome this problem, because you know that what I told, you will find patients in your clinic, they are using rheumatoid arthritis for quite long time, and they need it from time to time. So new group came out, and one of the member of that group, because they only selectively act on COX-2 or cyclooxygenase 2, so they are called COX-2 inhibitors, or selective COX-2 inhibitors. And one of the member of this group is celecoxib. Celecoxib. So, as we discussed that the COX-2, they are found in the inflammatory cells and vascular endothelial cells, but they spare the GI mucosa. Why? Because they don't act on the COX-1. So they don't act on the COX-1, so the side effects which are related with the blockade of the COX-1, that will not be there, whether it is the effect on the kidneys, whether it is effect on the GI mucosa. Okay, so what are the uses? RA and OA. RA stands for
rheumatoid arthritis.
rheumatoid arthritis, and OA stands for osteoarthritis. Very good. Rheumatoid arthritis and osteoarthritis, because in both the pain is common. The rest of the things may be different, but pain is common. Okay, what are the side effects? Side effects, sulfa allergy, because chemically celecoxib is like sulfur drug, so it can cause sulfa allergy. And second problem, that it can cause MI. Why? Because it causes thrombosis. It causes thrombosis, and thrombosis can lead to MI. It has no effect on COX-1. COX-1 related effect are on the blood, COX-1 related effect on the kidney, COX-1 related effect on the GI. Because it doesn't act on COX-1, so there is possibility for the myocardial infarction. So that is the problem with these drugs. Okay, go to next. Glucocorticoids. Inshallah, we will again discuss. We also previously discussed in respiratory renal module, but there we discussed them. They are used by inhalation. So very few times we need to use glucocorticoids in respiratory renal, in asthma and COPD. Injectables are oral. Mostly we use by inhalation. Here we use it both oral as well as by injection. Prednisolone, triamcinolone, and methylprednisolone. There are many. There are so many, but we just took those what are commonly used in the rheumatoid arthritis. We classify glucocorticoids based on the duration of action, how long they act, and secondly, we classify them based on the potency, how much smaller dose is required, the glucocorticoid will be more effective. Okay, what they will do? They will act by different mechanisms. If you recall, I hope you discussed with Dr. Fathi in the lipids metabolism that there is phospholipid bilayer. Phospholipid is converted into arachidonic acid. Arachidonic acid is converted into prostacyclins. Arachidonic acid is converted into prostacyclins and the leukotrienes, and then prostacyclin is converted into prostaglandins. So phospholipase A2 is required when the arachidonic acid is converted into prostaglandins. Okay, so it will block this enzyme. It will also block NFKB. NFKB stands for nuclear factor kappa B. If you remember last time, even in osteoporosis, we discussed the drugs that inhibit, that are the denosumab, that act on the nuclear factor kappa B. So these drugs, glucocorticoids, they also interfere with the nuclear factor kappa B ligand, because this is one inflammatory mediator. It causes inflammation in the body. Then they act on TNF, tumor necrosis factor. That is one another inflammatory mediator. And then leukocyte adhesion. Again, as we discussed in the beginning, that leukocytes, they play important role in the autoimmune disorder related inflammation. Okay, uses potent anti-inflammatory. It is potent anti-inflammatory. It reduces the inflammation like anything. No other drug can so effectively reduce the inflammation. First thing, we use these oral as well as IV, even intra-articular, into the joints. Sometimes the patient feels very severe pain in rheumatoid arthritis, so the doctors, they inject into the joints. So that is called intra-articular. Oral and IV are more common. What are the side effects? Unfortunately, they, although they are very effective anti-inflammatory, no one can beat them to reduce the inflammation, but we cannot use them for longer duration. Because when we use them for the longer duration, they start to interfere our body different mechanisms. And so for many times you will see maximum 2 weeks or 3 weeks, that is maximum. After that, we need to reduce the dose. Sometimes you will see in some patients, they use it in low dose continuously, but they will suffer from side effects. What are the side effects? First one is Cushing-like syndrome, or Cushing. I don't know whether you discussed Cushing or Cushing, or you didn't discuss anything about it. Cushing-like syndrome means that it will disturb our carbohydrate metabolism. It will disturb our protein metabolism. It will disturb our lipid metabolism. So all the three metabolism will be disturbed. there will be redistribution of the lipids or fats in the body. Like Cushing syndrome, what happens? There is moon-like face. What do we mean by moon-like face? Circular face. So the face will, because this is called the central region, so the fats, they are coming from the other parts and they accumulate in the face. So that is what we say moon-like face. Then hump, the shoulder, buffalo hump, the shoulder, the fats will accumulate on the shoulders. Then pendulous belly, the belly will be big, like pendulum in the physics. It will go like this. So these are the Cushing-like syndrome. Inshallah, we will discuss them in endocrine also. So second important problem that we face with glucocorticoids, that is hyperglycemia. As I told that it interferes with carbohydrate metabolism. So there will be high blood sugar level. There will be high blood sugar level. So that is also there. Next is osteoporosis, our last discussion, because it interferes with the calcium metabolism also. It not only interferes with the calcium metabolism but also reduces the absorption of the calcium. So it can also cause osteoporosis, even to such extent that glucocorticoids can cause osteoporosis. If you go back to our last lecture, bisphosphonates or any drug which are used in the treatment of osteoporosis, we say it is used for postmenopausal, age-related, idiopathic and steroid-induced or steroid-associated. Glucocorticoids, they are the steroids. Okay, so that are the problems with glucocorticoids. Okay, now we go to disease-modifying anti-rheumatic drugs. We have two types in this. One are called non-biologic or synthetic, and the other one are called biologic. Mostly we use non-biologic or synthetic because they are easy, they are less expensive. As I told, the patient needs to take the drugs for a lifetime. First one is methotrexate. Methotrexate, it will act on dihydrofolate reductase. This is the enzyme that is required in the folic acid synthesis. And folic acid is important for our nucleic acid synthesis, DNA and RNA synthesis. So it will block the enzyme that is dihydrofolate reductase enzyme. And this is the drug of choice. Drug of choice. You will see in your clinics, rheumatoid arthritis is mostly in females, and females take more care of the teeth. As you go to any dental clinic, most of the patients are females. So this rheumatoid arthritis, mostly all autoimmune disorders in female. So this is the drug of choice. Any patient suffering from rheumatoid arthritis, we will definitely try methotrexate. Okay? The problem that it takes 4 to 6 weeks that it will show its effect. It is slow in its effect. What are the side effects? The side effects are many. This is unfortunate. Bone marrow suppression, because it is acting on the immune system, so it will cause bone marrow suppression. So it can also act on the GI, like stomatitis, as you will discuss in oral medicine. Anorexia means loss of appetite, and nausea and vomiting. How we can minimize these oral related problems? By giving it intramuscular or IV. We have all the three options: oral, intramuscular and IV. Good thing that we use it once a week. Wide marra fil usbu. That is good thing. The rest is problem. Toxicity or fibrosis and necrosis. So we need to avoid in those patients who take alcohol. Alcohol, legs should not use methotrexate. Then pulmonary, it can cause hypersensitivity pneumonitis, although it is not quite common, but still it can cause. And the last one, teratogenic, that it should not be used in pregnant mothers. Why? Because it can affect the neural tube. So there could be neural tube defects. Okay, so there is one another. If the patient cannot use methotrexate, then he can use leflunomide. Leflunomide will act on dihydroorotate. The first one, methotrexate, it acts on dihydrofolate. It acts on dihydroorotate. Orotate is one another enzyme that is required in the synthesis of folic acid. And it acts as pyrimidine synthesis inhibitor. You already discussed pyrimidine during guanine in the DNA. Maybe you will discuss again in genetics. You started genetics or not yet?
No.
Maybe next year. Okay. So, use monotherapy for rheumatoid arthritis. Monotherapy means that only we can use leflunomide if the patient cannot tolerate methotrexate. What I told, the drug of choice is methotrexate, but for some reason the patient cannot take it. So those who cannot tolerate methotrexate, we can use leflunomide. Okay, sometimes we give it in combination also. Why? Because then we reduce the dose of each other. So the response takes place 3 to 6 weeks, 1 month almost, slightly better as compared to methotrexate. Methotrexate takes more time. What are the side effects? Almost same side effects. Diarrhea is there. Myelosuppression and bone marrow suppression is same. Hepatotoxicity, same like acts on the necrosis and fibrosis of the liver. Contraindicated during pregnancy, same like methotrexate, we should not use it during pregnancy. Why? Because it is the cousin of thalidomide. Thalidomide we discussed in general pharmacology is short limbs. It causes the teratogenic effect, it damages the fetus very commonly. So both methotrexate and leflunomide should not be used during pregnancy. Why? Because they damage the fetus. So that are the non-biologic. Now we go to biology. Because of these side effects, we use certain biologics. First one is, as even you will see in the case today, that is called tumor necrosis factor alpha antagonist or inhibitors, and that is etanercept. Etanercept, it acts, a fusion protein binds to the tumor necrosis factor alpha and prevents the activation of these inflammatory proteins. So that is tumor necrosis factors alpha. You will find nowadays they use it. Again, side effects are there. Second, it is injectable. It is injectable. We use it intramuscular. So injection site reaction. Injection site reaction. For example, we take it here in the arm. There is possibility for the injection site reaction. Second, it can cause infection or it can activate infection. If someone is suffering from latent tuberculosis, tuberculosis is there but not active. Hepatitis B is there but not active. Hepatitis C is there but not active. It will activate. It will activate. So we will take the past medical history of the patient before we start etanercept. And then it can also cause cancer. Why? Because it acts on many body cells and allergic reaction, as we discussed, especially at the site of injection. Contraindications where we should not use etanercept. First one, history of TB. If the patient suffered previously from TB, we will not use etanercept. Why? Because it is like live bullet, the patient will die. Why? Because you reactivate the tuberculosis. Then infection, active, chronic or recurrent. All the drugs, even if you remember I told last time in osteoporosis, denosumab, any drug that interferes with the body immunity, they will cause infection, especially bacterial infection. So it will also cause bacterial infections. And last one, it can also should not be used during CHF. CHF stands for
chronic heart failure.
chronic heart failure or congestive heart failure. Congestive heart failure, that is the contraindication. TB is the first one, second one infection, and third one is the CHF. But we can use it during pregnancy. Okay, so that is about disease modifying anti-rheumatic biologics. Okay, what time we should finish?
10 and a half.
10 and a half. Okay, so I think better to finish. Okay, we can finish. The next one, this is the discussion about the rheumatoid arthritis, and we covered all the three important components of the treatment of rheumatoid arthritis. The drugs which are used in the management of pain, the drugs which are used in the management of inflammation, the drugs which are used in the prevention of the progression of the disease. Now, another important group that are the muscle relaxants, as you discussed with Dr. Ammon, action potential. I think you already discussed.
Yes.
Sometimes we need to use muscle relaxants, muscle relaxation. Many times the pain in the body is due to muscle contraction. So we need to relax the muscles. So the drugs which are used, they are called muscle relaxants. The first one in this group, that is benzodiazepine, and the name is diazepam. Even in the beginning I told you it is a student drug. It causes very good sleep, especially during exam days. You need sleep, but it is not available in Saudi Arabia. Okay, now what does it do? It activates GABA receptors. What do we mean by GABA? Gamma amino butyric acid. I think you might have discussed with Dr. Fatih, or not yet. Maybe in CNS you will discuss. Gamma amino butyric acid. These are the neurotransmitters that are called inhibitory neurotransmitters. When these neurotransmitters, they are stimulated in the CNS, they give us sleep. They give us sleep. Similarly, they also relax the muscles. Okay, so it is poor muscle relaxant amongst many other things, but still it is used. What is the problem with the diazepam? That it causes sedation, sleepiness. It is good, but the problem is that it causes sleepiness. It acts on GABA A receptors. There are two types of GABA receptors, GABA A and GABA B. Remember, the drug that will act on GABA A receptors, those that will stimulate GABA A receptors, they will cause more sleepiness. Okay. The next one, that is called GABA mimetic, baclofen. Baclofen acts on GABA B receptors, gamma amino butyric acid B receptors. Diazepam acts on GABA A receptors, and baclofen acts on GABA B receptors, reducing spasticity in MS patients. MS patients, that is multiple sclerosis patients. It is a kind of disease, autoimmune again. There is spasticity, there is more muscle contraction. So to treat that, we use baclofen. Clear? Drowsiness and tolerance. Drowsiness, less than sedation. Drowsiness is less than sedation, but still not good, because when you feel drowsy, and especially for example you are driving, working on some machinery, so it is not good. Second problem, tolerance. Tolerance means we need to increase the dose. For example, we start from 5 milligram. After 1 month, 5 milligram will not work. So what we will do? We will increase it to 10 milligram. Then after again 1 month, 10 milligram will not be working. So what we need to do? Again we need to increase the dose. So that is the problem. Second one, withdrawal syndrome. When we stop it abruptly, all of a sudden, then there is withdrawal syndrome. Then the patient feels restless. So we need to reduce the dose gradually. Why it comes? Because we need to increase the dose to get the same benefit. You have patients suffering from multiple sclerosis. We start from 5 milligram and we reach 50 milligram. And then the patient says, I cannot tolerate anymore, I want to stop. And in the morning stop. No, then you need to stop gradually. 45, 40, 35, 30, 25, 20, 15, 10, 5, like this. Otherwise there will be withdrawal syndrome. Okay, we have one more, that is tizanidine. Tizanidine acts absolutely in different way. It will reduce the muscle spasm by stimulating alpha-2 receptors. If you remember, we discussed alpha-1, alpha-2 receptors in cardiovascular. Beta-1 and beta-2. Alpha-2 receptors, they are present in the CNS. They are present in the CNS. So it is centrally acting. It will cause the muscle relaxation. The problem that we face with tizanidine, that it causes drowsiness, sleepy, then hypotension, because it acts on the alpha receptors. So the drugs that acts on the alpha receptors, that can reduce the blood pressure, because most of the alpha-1 and the alpha-2 receptors, they are present in the blood vessel. So there will be vasodilation, and that can lead to hypotension, and then dizziness and dry mouth. Because when we stimulate alpha-2 receptors, it has anticholinergic-like effect. It will cause a reduction in the salivation. Another group, again, they are not available, or they are available only on prescription in Saudi Arabia, that are gabapentin and pregabalin. If you see, both have gabapentin. The other one is pregabalin, because both of them, they act related with gamma aminobutyric acid. They are used as anti-epileptic. Anti-epileptic means the drugs which are used in syrup, but they are also used as muscle relaxants because they have some activity. But not good choice, because they cause, even WHO now says it causes addiction. You understand addiction. Once you start, then you cannot stop. That is the whole story of our today's discussion. Everything is finished in this lecture. Clear?
Clear.
Okay. Inshallah, after some time we will start.
This one's